Hello, good morning everyone. Today we are moving to the lecture Psoriasis and Lichen planus. So, what is psoriasis? Which is an inflammatory hyperplastic disease of the skin characterized by erythema, elevated scaly plaques, chronic relapsing condition, then which is course of disease often unpredictable. Symptoms of psoriasis, which is like thick silvery scales, cracked dry skin, itchiness will be there, redness, scaly patches, then nails that are pitted and cracked or crumbled appearance. So the prevalence, which is varies across the region due to the environmental and general factors, pediatric psoriasis is rare. Most common in boys, which is age up to 6 to 10 years, and girls, which is 11 to 15 years. And a family history present in of a pediatric cases, psoriatic arthritis is there, which affect 3 to 24% of psoriasis patient with onset typically between 35 to 50 years. Common triggering factors for psoriasis: infection, skin trauma, psychological stress, drugs, sunburn, metabolic factors, and hormone factors. Psoriasis, which is a T-cell mediated autoimmune disease, and unknown skin antigens stimulate the immune response. Antigen-specific memory T cells are primary mediators, lead to impaired differentiation and hyperproliferation of keratinocytes. Clinical presentation: classic psoriasis, which is well defined and sharply demarcated, round or oval shaped lesion, usually symmetrical erythematous raised plaques covered by white silvery scales. Common sites affect the psoriasis, which can be any part of the body, typically scalp, elbow, knee, and sacrum. Which extent disease varies. Type of psoriasis: chronic plaque, gudate, flexural, ectodermic, pustular, and local forms are there. Most common type affect approximately 85%, features pink, well-defined plaques with silvery scales. Lesions may be single or numerous. Plaques may involve the large area of the skin, classically affect elbows, knees, buttocks, and scalp. So in this case, auspicious sign will be positive, which means we will scrape it by the glass. That time we can see the shedding of the skin. After that, you can see a membrane appearance, that is known as Becali membrane. Again, you will scrape it. At that time, you can see the blood spots. So that is known as auspicious sign. And apart from that, you can see a roundish appearance. So that is known as ring of Von sign. So moving to gudate psoriasis, which is numerous small lesions, approximately 1 centimeter in diameter, which is pink with less scales than plaque psoriasis. Commonly found on trunk and proximal limbs, typically seen in individuals, often preceded by an upper respiratory tract streptococcal infection. Lesion in skin fold, articularly growing, gluteate cleft, axilla, and submammary regions, often minimal and absent of scaling, may cause diagnostic difficulty when genital or perianal region is affected. Ectodermic psoriasis, which is a generalized erythema covering entire skin surface, may evolve slowly from chronic plaque psoriasis or appear on eruptive phenomenon. Patients have become febrile, hypothermic, and dehydrated. The complication, which include cardiac failure, infection, malabsorption, and anemia. As for the normal skin turnover, which will be 50 to 75 days, but 70 days, but in the case of psoriasis, there will be rapid shedding. So in the case, there will be increased epidermal turnover. So in the case of psoriasis, within 4 to 5 days, the skin will be shedded off. So moving to pustular psoriasis, two forms are there: localized forms and generalized form. Localized form, which is more common and present as deep-seated lesions with multiple small pustules on palm and soles. Generalized form, uncommon, associated with fever and widespread pustules across the body, inflamed body surface. Palmoplantar psoriasis, which can be hyperkeratotic or pustular, may mimic dermatitis. Look for psoriatic manifestation elsewhere to aid the diagnosis, possibly which is aggravated by trauma. Scalp psoriasis, which is varies from minor scaling with erythema to thick hyperkeratotic plaque, may extend beyond the hairline. Patient scratch may produce asymmetric plaque. Nail psoriasis, which is may be present in patient with any type of psoriasis, can take several forms: pitting, sublingual hyperkeratotic, oncolysis, which means the nail separate from the nail bed at free at the edge, and oil drop sign also will be positive. So this is known as spitting. Psoriatic arthritis, which is approximately 5 to 20% have associated with arthritis. Then five major patterns of psoriatic arthritis are there, which is distal interphalangeal involvement, symmetrical polyarthritis, psoriatic spondyloarthropathy, arthritis multiplicans, and oligoarticular, which is asymmetrical arthritis. For the diagnosis purpose, like other dermatological disorders can resemble the psoriasis, which is clinically according to the appearance, distribution, history of lesion, and family history. Important to consider non-cutaneous complication. Differential diagnosis, localized patches and plaques, which you can see now the tinea, ischemia, superficial basal cells, seborrheic dermatitis, and cutaneous T-cell lymphoma. And gudate psoriasis is there, which you can gudate things will be there. You have to differentiate with pityriasis alba, drug eruption, secondary syphilis. Flexural forms are the ectodermic forms and palmoplantar forms. So moving to localized patches or plaques. If in the case of tinea corporis, which affect the body, lacks symmetrical lesions, presence of peripheral scales, and central clearing, which means over here you can see the central clearing. Discoid eczema, which is an inneralized patches, more pruritic than psoriasis, lack of silvery scales we can see, and less vivid color than psoriasis. Superficial basal cell carcinoma or Bowen's disease, which is an asymmetric lesions, either single or few in number, which performs biopsy if the lesions are resistant to topical psoriasis treatment. Seborrheic dermatitis, which is characterized by a yellowish scaling and erythema localized to many of same areas as psoriasis. Diffuse scaling differ from sharply defined psoriatic plaque, which affect furrow of the face. Okay, cutaneous T-cell lymphoma, which is like a rare discoid lesions, asymmetrical and less scaly than psoriasis, which may present with fine atrophy and be resistant to anti-psoriatic therapy, and investigate biopsy to confirm diagnosis. Gudate psoriasis, in the case of secondary syphilis, search for the characteristic primary syphilitic lesions, lymphadenopathy, and lesions of the face and palms and soles. Okay, then we should conduct the serology and skin biopsy. Flexural psoriasis, which is you have to differentiate with the tinea cruris, which affect the groin area, which is characterized by central clearing and with advanced edge. Non-silver lesions with fine scales, and particularly you can see at the periphery. The lesion frequently extend more on left side. Flexural psoriasis, atopic eczema, often associated with asthma and hay fever, which means a seasonal fever, like classic psoriatic needles involvement and sharply demarcated scaly plaques. Candidiasis, which is a characteristic peripheral pustules and scaling, differ to psoriasis. Yeast culture are diagnostic thing. Tinea manum, ringworm of hands, fine powdery scales, particularly involving at palms and palmar creases, usually asymmetrical. Hand and foot eczema, which is a hyperkeratotic form difficult to distinguish from psoriasis. Biopsy can assist the diagnosis, and we should look for the history of atopy and lack of psoriasis elsewhere on the body, and evidence of eczema wherever is it present over the skin. Palmoplantar psoriasis, palmoplantar of palms and soles, which is like this hydrotic eczema and present as clear vesicles, contrast to yellow or white pustules in pustular psoriasis, combined by intense pruritus. Treatment, general measures like we should reduce and or eliminate the potential triggering factors like stress, smoking, alcohol, trauma, drugs, and infections. The therapy like emollients, which means include aqueous cream, white soft paraffin, and wool fats. Regular use can decrease the pruritus, reduce the scale and penetration of concomitant topical therapy. Hydrate dry and crackle skin. Soap should be avoided. And topical therapy like calcipotriol, which is a synthetic vitamin D analog for chronic plague type psoriasis, reverse abdominal keratinocytes change by inducing differentiation and suppressing the proliferation of keratinocytes. Systemic therapy, methotrexate, most commonly used in systemic treatment of psoriasis, slow epidermal cell proliferation and act as an immunosuppressant. In this, while we giving this methotrexate, we should monitor the kidney, liver, bone marrow function. Systemic therapy is a oral retinoid for treatment of all forms of severe psoriasis. Once daily oral therapy. If the patient is pregnant, we should avoid it. Okay, topical treatments like corticosteroids, we can give vitamin D, calcineurin inhibitors, salicylic acid phototherapy, then psoralen with UVA therapy. Systemic medications like methotrexate we can give in this case. Cyclosporin and acetrin. Biological therapies like drugs which are typically prescribed for moderate to severe psoriasis. Examples which include TNF alpha inhibitors, interleukin 17 and 24. Systemic treatment for psoriatic arthritis. For the individuals with psoriatic arthritis, systemic medications, disease modifying anti-rheumatic drugs, biologics can help manage this joint symptoms. Lifestyle management, moisturizing is needed, reduction of the stress and healthy lifestyle. So, moving to the diagnosis and management of psoriasis, which is in summarized form. This is a chronic inflammatory disease of the skin, T-cell mediated disorder, classic presentation characterized by red, scaly plaques. Management should address both medical and psychological aspects. Treatment include topical therapy, phototherapy, systemic therapy, and biological agents. So we were moving to lichen planus. It's a disease of skin and or mucous membrane that resembles with lichens. It is thought to be the result of an autoimmune process with unknown initial trigger, where the trigger is a non and lesion is known as lichenoid lesions. So no racial predisposition is there. The lichen planus, which affects the movements more compared to men, which is in 3:3:2 ratio, and age to more 2/3 of lichen planus patients are age 30 to 60 years. However, the lichen planus can occur at any age. Time period, which is a chronic disease and has a subacute presentation that lesions appear usually 1 to 2 weeks after being exposed to stimulus. That condition clear ups within 18 months, but may come and go for years. Removal of stimulus could be result in a quick resolution. Examples, that is lichen planus is caused if it is caused by a kind of medicine. The rash should be resolved once the medicine will be stopped. Symptom statement: 3 types of lesions are there: mouth, skin, and other. Oral lesions may be tender or painful, are located on the side of the tongue and inside the cheek or gums, look like blue-white spots is there, and lacy networks. Gradual increase in size of the affected area sometimes form painful ulcer. Lesions are usually found on the inner wrist, legs, or genitals, are itchy and have even side symmetrical and sharp borders. Occurs in single lesions or clusters that at the site of skin injury. Then may be covered with the wick hamstray and are shiny and scaly by appearance and have a dark reddish purple color on the skin and or gray white in the mouth. May develop blister or ulcer. Treatment goal: the goal of treatment is to reduce the symptom and speed healing. If the symptoms are mild, it may not need any treatment. Other manifestations like dry mouth, hair loss, metallic taste in mouth, and rigid nails or nail abnormalities. Treatments like can include the antihistamines, medicine that calm down the immune system, such as cyclosporin, lidocaine, topical corticosteroids to reduce the swelling and lower immune response, corticosteroids shot into a sore, and a vitamin A cream, dressing, and UVA therapy. Which is cell-mediated immune response of unknown skin, which may be found with the other disease of altered immunity. And lichen planus has been found to associated with a Hep C virus infection chronic active hepatitis, and primary biliary cirrhosis. That it is most likely immunological mediated reaction through the pathophysiology is unclear. Sign and symptoms. The lesion initially developing on flexor surface of the limbs and generalized eruption developing after weeks or more and maximum spreading within 2 to 16 weeks. Pruritus of varying severity, oral lesions that may be asymptomatic, burning, or even painful. In addition to cutaneous eruption, the lichen planus can involve the following structures: mucous membrane, genitalia, nail, scalp. Clinical presentation. Several variations are there, which follows: hypertrophic lichen planus, atrophic, erosive or ulcerative, follicular, and linear vesicular actinic, and lichen planus pigmentosus and pemphigoids. Clinical forms: reticular, erosive, papular, plaque, atrophic, and bullous forms are there. Diagnosis: direct immunofluorescence, which study reveals a globular deposition of immunoglobulin and complement mixed with apoptotic keratinocytes. No imaging studies are necessary. Microscopy of OLP. Management: is a self-limited disease that usually resolves within 8 to 12 months, and mild cases can be treated with fluorinated topical steroids. More severe cases, especially those with the scalp, nail, and mucous membrane involvement, may necessitate more intensive therapy. Pharmacological management: cutaneous lichen planus and lichen planus of oral mucosa. For the cutaneous lichen planus, topical steroids, particularly class first and second ointment. Then for the lichen planus, topical steroids, topical cancer inhibitors. Patient with widespread lichen planus may respond to the following: narrowband, broadband UVB, or psoriasis with UVA. Which I told you is a flat topped skin rashes. So you have to remember the 9 P's, which they are: papilloscamus is disorder, pruritus, plain topped, polyangular, purple colored, papillary plaque lesions, pigmentation present, pterium impressions, present, formation, penile, and la lesions. So these are the 9 P's which you have to mention. You have to by heart. So thank you for listening my lecture. Have a nice day.